Hi, my name is Terry Mamounas. I'm a breast surgical oncologist. I'm the director of the Comprehensive Breast Program at the Orlando Health Cancer Institute here in Orlando, Florida. So the question is to describe the surgical approach of other breast tumors such as fibroadenoma, phylloides tumor, breast angiosarcoma, and implant-associated large cell lymphoma. So let's start with fibroadenomas, which, as we all know, are benign lesions and typically encountered in young premenopausal women and adolescents. And they typically present as well circumscribed for mobile masses. They're often lobulated. And these are typically hormone-sensitive lesions, so they tend to wax and wane with the menstrual cycle of a premenopausal woman. And they're often painless, although they can occasionally cause pain and tenderness depending on the size and the time of the menstrual cycle. So fibroadenomas can generally be observed without surgical removal, as long as they do not cause any discomfort to the patient or bother the patient in any other way. For example, some people have cosmetic issues if there's a large fibroadenoma in their breast, particularly if they're sizable. So if a presumed fibroadenoma is going to be observed, I think one important point is that a core needle biopsy is needed to confirm the diagnosis and also to rule out other pathologies, such as, for example, a phylloides tumor. Unless per patient's history and prior tumor imaging, this lesion can be present for many years. Somebody comes in and says, I have this for 15 years. Obviously, no need to biopsy. We can observe it as long as we feel comfortable with the imaging. Now, if the patient has a newly identified small fibroadenoma appearing lesion, let's say under 2 centimeters, that for whatever reason is bothersome to the patient and wishes to have it removed, one can do surgery and proceed with surgery without any histologic confirmation of fibroadenoma if the ultrasound points to that diagnosis. However, for women that present with larger fibroadenoma appearing lesions and the patient desires to have them removed, it's prudent actually to proceed with a core biopsy prior to surgery to rule out phylloides tumor, because that will alter the surgical plan. And so typically for fibroadenoma, surgery can be performed through a periareolar incision, depending on the location, of course. And typically there is no need to remove additional breast tissue around the lesion. So typically we can sort of deliver the lesion, shell out the lesion, and leave as much breast tissue back. And usually that fills in the gap very nicely. So that's the typical approach for fibroadenomas. Now, phylloides tumors are usually larger and more aggressive locally, and they can be classified, as we know, into benign and malignant phylloides. And their management typically involves wide local excision of the lesion, ideally with a 1 centimeter margin, although that cannot always be the case. And this is all sort of provided that can also be done with a good cosmetic result. So for large phylloides tumors, where a good cosmetic result cannot be achieved after a wide excision, one obviously can consider a wide excision with less than 1 centimeter margin, or total mastectomy. It's obviously another alternative. Even for malignant phylloides tumor, typically axillary lymph node removal is just generally not indicated, because these tumors behave like sarcomas and usually do not involve the nodes. Now, breast angiosarcomas are actually rare, very aggressive tumors that usually occur in breasts that have been radiated in the past, but rarely can also occur de novo without prior breast radiation, particularly if there's a prior lymph node surgery. They often need a mastectomy for local control because they usually are sizable, although if they're small, wide local excision can be considered. However, generous margin needs to be obtained. These are aggressive lesions that they tend to recur both locally and systemically, and they're typically not well-established adjuvant therapies, although radiation can be considered if not previously used, and occasionally chemotherapy can also be given, but the chemotherapy efficacy is actually not very good. And lastly, implant-associated anaplastic large cell lymphoma usually actually presents as a peri-implant effusion in a patient who typically has texture implants. And those are usually indolent lymphomas that are typically cured by surgery to completely remove the implant capsule and the implant. And regarding the etiology is interesting. There's a bacteria, a gram-negative non-fermenting bacillus called Ralstonia that has been implicated in their pathogenesis, which is also interesting because, for example, H. pylori is a non-fermenting gram-negative bacillus that has been implicated for gastric lymphoma. So there may be a bacteria etiology to this, but also requirement is usually for texture implants to be present because it forms a nice scaffolding for the bacteria thing to grow and then lymphoma to occur. And adjuvant chemotherapy can be given. For example, CHOP or ABVD has been reported as an option. And this is used only for infiltrative disease that cannot be completely resected. And sometimes radiation therapy can also be considered in these cases. Now, interestingly, the FDA does not currently recommend to prophylactically remove all texture implants as the disease is actually very rare. So even women that have texture implants, the majority of them will not develop an anaplastic large cell lymphoma.